Hi, good morning, everybody, and welcome to Head Talks, as well as our last grand rounds of 2023. This is always one of my favorites of the year, and I hope that you'll find today's talks to be interesting, informative, and compelling. If you're unfamiliar with this format, we have three speakers today who only have about 10 to 12 minutes to present on their topic. I know that a lot of time, energy, and effort has gone into crafting these talks to be as effective as possible. Mark Twain is credited as saying, "I didn't have time to write a short letter, so I wrote a long one instead." And I think that the same principles apply here. It's a lot harder to edit, to pare down, and to communicate something meaningful in a short amount of time than if you have all the time in the world. But I know that our three speakers today are up for the task, and I hope that you will join me in welcoming them. As a reminder, you can ask questions of the speakers at any time using the Q&A function, but we're not going to answer them until we do a joint Q&A at the end. So make sure to note who your question is addressed to when you submit it. And so now I will pass it over to Dr. Pretsky to introduce our first speaker this morning.
Well, good morning, everyone. It's my pleasure to introduce our first speaker, Dr. Taylor Smyth, a graduate of Dell Medical School of the University of Texas at Austin, where he was a member of its inaugural class. Dr. Smyth is currently a fourth-year psychiatry resident at the UCLA Semel Institute, where he has distinguished himself in promoting psychotherapy training, education, and advocacy. He's a member of both the clinician educator and psychodynamic psychotherapy concentrations, and as co-chief resident for psychotherapy, Dr. Taylor has made significant contributions in psychotherapy and psychology education for psychiatric trainees. To highlight just a few, Dr. Smyth directs the Psychoanalytics Classics Journal Club and the Master Clinician Rounds, responsible for bringing them back after they lapsed during the COVID crisis. He has created a lecture series on transdiagnostic formulation, another on psychoanalytic psychology, and is now working on a third based on today's topic, psychodynamic psychopharmacology. He also contributed to the recent psychotherapy curriculum redesign proposal, and he's drafted a volunteer clinical faculty survey related to equity, diversity, and inclusion in psychotherapy supervision. In addition to his training at UCLA, Dr. Smyth is enrolled in the Psychoanalytic Psychotherapy program concurrently now at the Los Angeles Institute and Society for Psychoanalytic Studies, and he just recently completed a month-long rotation in psychodynamic psychiatry at Austin Riggs Center in Stockbridge, Massachusetts. For this, he was awarded a UCLA Psychiatric Clinical Faculty Association Metzner Psychotherapy Scholarship. So please join me in welcoming Dr. Taylor.
Thank you very much, Dr. Pretsky. All right. In July 1989, President George Bush signed into law House Joint Resolution 174, declaring the 1990s the decade of the brain. The resolution was preceded by a report from the NINDS published January 1989 titled Decade of the Brain, Answers Through Scientific Research. It was a time of palpable optimism about the promise of biological psychiatry, a spirit that was captured in the introduction of the report, which stated, "The nation stands at the threshold of enormous opportunities in the neurosciences. The foundation for future advances already has been laid, offering the potential for incalculable reductions in the human and economic costs of brain disease. The immediate and long-range benefits of research on these afflictions cannot be overestimated for the health of the nation." Since then, treatment resistance has emerged as a widespread clinical phenomenon in psychiatry, despite decades of progress in neuroscience, genetics, and psychopharmacology. Treatment resistance is now recognized across a variety of psychiatric disorders, including schizophrenia, bipolar disorder, major depressive disorder, and obsessive-compulsive disorder, with an estimated prevalence ranging anywhere from 20 to 60%. In depression, treatment resistance has been associated with significant reductions in mean quality of life, increased risk of suicide, and increased healthcare utilization, including both inpatient and outpatient services. And the scale of the problem has been reflected in the psychiatric literature. Between 1980 and 1984, there were only 36 references to treatment resistance in the psychiatric literature. Since then, that number has increased exponentially every 5 years, so that between 2015 and 2019, there were over 3,200 references to treatment-resistant psychiatric conditions. In part, these trends reflect advances in our ability to identify treatment resistance, but they also raise serious questions about the extent to which neuroscience and drug development have led to meaningful improvements in psychiatric outcomes. In the wake of such incredible optimism about the promise of biological psychiatry, we might ask ourselves, well, how did we get here? And there are a number of different factors that have contributed to these trends, but I want to highlight three factors in particular that have worked in tandem to produce an impoverished model of treatment resistance, one that neglects the real and significant effects of meaning and relationship on pharmacological treatment outcomes. A categorical empirical approach to diagnosis, an illness-centered model of care, and an overly narrow definition of evidence-based prescribing have contributed to what Thomas Gutail described in 1982 as a delusion of precision, the idea that patients can be modeled as passive recipients of concrete, specific, and straightforward medical interventions. So under this model, we often talk about the 5 Ds of treatment resistance: diagnosis, dose, duration, drug mechanism, and different treatment altogether. And this model provides valuable information about what to prescribe for the average patient. But in many cases, particularly those that are deemed treatment resistant, this approach provides very little guidance on how to prescribe for the individual patient, a complex person who comes into the treatment relationship with their own history, personality, expectations, and unique developmental considerations. The reality is that a large and compelling evidence base indicates that non-drug factors, so factors that are unrelated to the putative biological mechanism of a medication, exert a significant effect on treatment response. For instance, we know that up to 80% of antidepressant response can be attributed to non-pharmacologic effects, such as the placebo response, and at least a portion of the remaining drug-placebo difference may be effectively explained by unblinding. We also know that it matters who is prescribing the drug. In 2006, a team from the University of Wisconsin published a reanalysis of outcome data from the TDCRP, which showed a robust prescriber effect, indicating that individual psychiatrists were responsible for more of the variance in outcomes than the actual treatments. And when the authors stratified outcomes by prescriber, they found that the most effective third of prescribers achieved better outcomes with placebos than the least effective third of prescribers achieved with active antidepressants. So in summary, there is strong evidence that pharmacotherapy is also a psychological treatment. It's clear that medications exert their effects via multiple pathways. Some are mediated biologically through their actions at various receptor sites, while others are mediated symbolically in the context of the doctor-patient relationship. In other words, how we prescribe often matters as much, if not more, than what we prescribe. Over the years, various frameworks have emerged to explore the role of non-drug factors in treatment outcomes, originating in the psychoanalytic literature, then resurfacing in the concept of set and setting in early psychedelic research. Many of these factors have been investigated in the literature on the placebo and nocebo effects, and much has been written about the importance of the therapeutic alliance, doctor-patient communication, and shared decision-making in the common factors literature. Taken together, a wide range of non-drug factors or meaning effects have been shown to affect pharmacological treatment outcomes. These include medication factors, things like the color or cost of a drug, patient factors such as personality traits, attachment style, ambivalence, motivation for treatment or expectations for treatment, and factors that are unique to the prescriber and therapeutic relationship, for example, therapeutic alliance or quality of communication. Despite this, there is to date no widely accepted method for systematically incorporating these findings into clinical practice. One method that has been developed, based on the work of David Mintz at the Austin Riggs Center, is Psychodynamic Psychopharmacology, which aims to integrate an objective, descriptive, population-based approach with a patient-centered, psychodynamically informed perspective that leverages the effects of meaning and relationship on treatment outcomes. This model recognizes that patients have complex attitudes, hopes, and fears about treatment, and that some of these factors may be in conflict. With this in mind, it draws upon foundational concepts in psychodynamic psychotherapy to identify and address sources of ambivalence and resistance as they emerge in the unfolding treatment relationship, helping both patients and prescribers to resolve psychological and interpersonal barriers that may be working against functional improvement. By orienting the treatment around the patient's developmental goals and exploring the meanings of both treatment and illness, the This model places the patient at the center of care. Symptoms can be addressed not just as problems in their own right, but as potential solutions to internal conflicts, dysfunctional relationships, or intolerable feelings. Working from this perspective, we can expand our model of treatment resistance beyond the objective descriptive lens to include the unique dynamics of the patient, the developmental context of the treatment, and of course, our contribution as prescribers, which may include countertransference prescribing, enactments, or failing to recognize when medications may be impeding broader developmental goals, either by reinforcing self-defeating narratives, functioning as a defense, replacing adaptive coping skills, or serving as a proxy for interpersonal relationships. So what does this mean clinically? Well, first, it means understanding and incorporating the literature on how to prescribe, both to guide individual treatment decisions, but also to get the most out of each medication trial. It also means treating the patient, not the illness. Whereas an illness-centered model can highlight what makes patients similar, a psychodynamic approach to prescribing can help to clarify what makes patients different and how those differences impact treatment. This approach should also encourage us to rethink the concept of precision psychiatry. Rather than focusing exclusively on drugs, genes, and neurobiology, a relational approach to pharmacotherapy can provide a complementary set of skills and principles to tailor our treatments to the individual patient. Now, one of the unintended consequences of a pharmacocentric treatment model is that it can actually disempower patients by locating all of the expertise and authority in the doctor, thereby undermining the vital role of patient agency in the path to recovery. Psychodynamic prescribing encourages patients to assume a more active role in their recovery by acknowledging the impact of psychosocial factors on treatment outcomes and inviting them to explore their fears, expectations, and ambivalences about treatment in a collaborative working relationship. And nowhere is this more valuable than in the treatment of patients with complex emotional needs and comorbidities. Not coincidentally, treatment of these patients in the community often involves the use of polypharmacy and other interventions that may lack a clear evidence base for their efficacy. Psychodynamic prescribing can have a containing and conservative effect on our work with these patients, providing a framework to minimize irrational pharmacology and adhere more closely to the existing evidence base, despite its limitations. By embracing a balanced, pluralistic approach, psychiatrists can use all of the tools at their disposal to maximize the benefits of their treatments while minimizing potential harms. And I want to take a moment just to acknowledge the many different people who have been instrumental in my development as a psychiatrist over the last 4 years, including all of my attendings and mentors, the program leadership, members of the volunteer clinical faculty, and of course, all of my co-residents. I also want to thank my therapy supervisors, both through PDPC and RPC, as well as the staff at the Austin Rick Center who graciously welcomed me into their community for a visiting rotation earlier this year. Thank you very much for your time.
Thank you so much, Taylor. Really fantastic. Really kind of enjoyed hearing that and seeing that perspective brought to the work that we do every day. Thank you for that. Our next person who will be doing the introduction is Dr. Andrew Kim, who will be introducing our next second speaker.
Hi, thank you, Jonathan. So good morning. My name is Jinit Kim. It is my great privilege to introduce the next speaker, Dr. Jinit Desai. Dr. Desai comes to us from the University of Illinois, Chicago, where he double majored in neuroscience and philosophy, appropriately enough. He went on to earn an MPH and a Fulbright Award to teach English in Columbia before attending UIC Medical School, where he was a member of AOA and Gold Humanism Honor Society. He's currently a third-year resident at NPI with the Clinician Educator concentration. I had the pleasure of working with Dr. Desai on the inpatient mental health service at West LA VA, so I know this topic is well within his wheelhouse. If it wasn't obvious from his education and credentials, Dr. Desai is inquisitive and thoughtful and has a knack for being able to zoom in and out with his patients, seeing both the big picture and the small. I'm certain we have much to learn from Dr. Desai's insights over the course of his talk, The Integration Problem and Enactive Psychiatry. So please join me in welcoming Dr. Desai for his head talk.
Thanks, Dr. Kim, for that very kind introduction. and thank you everyone for being here. It's an honor to be presenting alongside Dr. Smyth and Dr. Wright, a couple of my clinical heroes. Yeah, I'll be talking about the integration problem and enactive psychiatry. My hope is to share a little bit of what I've been curious about during residency, and how I try to piece things together. And I'm by no means an expert in this area, but I hope that I can put a name to some things that I believe you've already felt and intuited and concluded in your own clinical work, and offer a framework for how psychiatric nosology, diagnosis, treatment, prevention, and prognosis can evolve in the years to come. I think it'll piggyback well off of Dr. Smith's talk, or so I hope. This question continues to generate a lot of conversation and discourse. The harmful dysfunction analysis, prominently featured in Wakefield's 2007 analysis. It does a lot of work, and it often serves our purposes, but what constitutes dysfunction and what constitutes harms are by no means self-evident. And how we answer this question is relevant not just on a day-to-day when working with patients and when they ask, what do you mean by depression? What do you mean by psychosis? But in terms of how we think about our clinical problems, how we design trials, and how we conceptualize treatments. And sometimes when I'm thinking about what's happening with the patient, what we can do for a patient, I'm thinking about what might be happening at the level of the brain, what might be happening within the context of school, family, how they're thinking about things, the communities they're situated in, their histories. But when I'm writing up the formulation, it often feels like a Where's Waldo, where I'm hoping that as I bring all these things together, their cause of their distress is somewhere in the picture, but I don't quite know how to tie things together. And this difficulty with the biopsychosocial approach is called the integration problem, where it, over the last 40 or so years after Engel's Engel put it out into the mainstream, it has done a lot of good in helping broaden what we regard as sources of distress, but it has not provided a way of linking the different levels, so to speak, and thereby has not served to guide a causal framework for intervention and a story, so to speak, that brings what's happening at the brain together with what's happening at the level of communities. And this comes up when we're working with patients, but also in media, when suicidality features in both The Little Prince and Joachim Trier's Oslo, August 31st, in different ways. And in both of those films, the suicidality is not, you can't draw a line from what's happening in the brain to that person's relationship with death and dying. And enactivism, I think, tries to address both the limitations of harmful dysfunction as the sole basis of mental disorder, and address the integration problem that stems from the biopsychosocial formulation of mental disorder based on harmful dysfunction. There is a little bit of theoretical scaffolding that it can be a little esoteric, but I think it's worth offering as an activism can then be situated within a larger cultural eco-social systems view of psychiatry. And the upshot is or I should speak for myself here. Throughout residency, I felt this yearning to situate mental distress and disorder within the unique personhood of each person that comes to us seeking help, without reducing what's happening to what's happening at their brain, but also without rendering them a powerless agent to the forces of transnational extractive capitalism and anti-Black, racist, oppressive policies at the legislative and local levels. There has to be a middle way between normativism and naturalism. And I think enactivism stems from a wish to center the lived experience of the person and not make it so that the psychology, the self-narration, the self-reflexivity, the existentialist domains of mental distress are merely relativistically positioned against what's happening in the brain and what might be happening in the community, but really at the essence of what we're working with. And so some of the scaffolding involves this notion of autopoiesis, the self-perpetuation of our identities. Much like a cell mitotically divides, we perpetuate ourselves into the future. And there's an operational closure that binds together our sensory motor schemes and regional identities. So the idea is, look, here's Tefiti, a mountain, rainforest, goddess. We're not so different in that whether we're doing laundry, walking the dog, playing the violin, being a parent, being a friend, there are these roles that we enact in space and time, that as we enact them, they interact with each other and they feed into making the whole of who we are. And in that process, it feeds back on how we play out those identities. And in that sense, we are operationally closed. There is a dynamic causality between how we play out our identities and the identity that does ultimately get played out. And the way that enactivism tries to avoid any kind of semblance of the recurrence of the blemish that remains pathologizing homosexuality decades back is to consider affordances, that our identities are contingent upon the social, cultural affordances that we find ourselves within. And we are in dialogue with these affordances in our maintenance of identity. So how does this fit into a framework that might help guide diagnosis, but also intervention? When we look at Tefiti, imagine now she presents depressed. I think intuitively, when we see someone, we're already thinking about, okay, what's happening at the level of the brain? How are they thinking about themselves? What relationships do they have? How are they thinking about those relationships? Where are they living? What is it like where they live? What have they been through, and so forth? And we know that these things are interacting with each other in the ways that these lines demonstrate that they probably are. But how do we organize them in a way that makes sense and that maintains at the center of our analysis of dysfunction or distress the personhood and that person's lived experience? There's different kinds of hierarchies, but the one that's probably most relevant to us is control hierarchy, where each basic unit is a feedback loop. And we can maintain a dynamic causality with biological relativity, positing that things don't have to start in the brain. The family can be just as basic as the brain. The community can be just as basic as the family, and so forth. And enactivism might be best thought of within a cultural eco-social systems view, most specifically the one put forth by Gomez Carrillo and Kiermaier actually this year, where as part of a 4E cognitive science, human function is embedded in context, it's extended in that it engages with the affordances that are around each unique individual. It is embodied in that our physiology and our experience are intertwined, and it is enacted in that we are playing out roles and thereby demonstrating our agency. And within these loops, there is at its heart narrativity, reflexivity, existentialism, and meaning making. We are sense making, sense ordering beings, and human ecological niches are essentially social. And I think that as we're trying to think about how do we bring together the various levels while maintaining the individual differences that are meaningful at the level of the brain versus at the level of community, thinking about how they might relate in this way might help us, render the unique personhood and psychology of someone not simply as something to be put alongside a list of other things that might be relevant, but at the core of what we're calling mental disorder or distress. So I don't think this is revolutionary, perhaps, and it might not necessarily change how you practice on a day-to-day. But I think that this offers hope for how we might consider, for example, clinical trials in the future, where we're not just assessing what happens when we give this person this chemical concoction and how do their scales look in 6 months, but rather when we intervene in this section of this ecological system of dynamic factors, how do the relationships change? How does their self-image change? How does their neurophysiology change to render origin more dynamic and flexible? Thanks.
All right. Thank you so much, Jinit. Really interesting, thought-provoking talk. And I now have the distinct pleasure of introducing our third speaker for the morning, and that will be Dr. Hilary Wright. So Hilary is a California native. She comes to us from San Diego. She completed her undergraduate work at USC before going to do a Master of Science in Physiology at Georgetown University, and then an MD with an MPH from Tulane. From there, we were very excited that Hilary matched with us here at UCLA. She did her intern year at in the Harbor track before joining us on the main campus starting PGY2. I first really got to know Hilary when she joined the clinician educator concentration as a PGY3, and I was very quickly impressed by her very thoughtful and methodical approach to teaching. She is absolutely a powerhouse in this regard and was actually awarded with the biggest impact award last year for her lectures on conservatorship. Today, she'll be talking with us about dissociation as a symptom in mental health, one that we often really don't spend a lot of time talking about. So I hope that you'll join me in welcoming Dr. Wright to talk with us about this very important topic.
Thank you, Dr. Halt, for that introduction. And I'll echo Dr. Desai's words. It's an honor to be up here alongside him and Dr. Smyth. So today I'm going to be talking about dissociation as a symptom, exploring why dissociation is relevant for us to consider and think about in our clinical evaluations. This topic is interesting to me because I felt a discrepancy between my didactic teaching and my experience encountering dissociation in the clinical setting. I'm going to discuss representation of dissociation in the media, define dissociation as a concept, and finally, review how ubiquitous dissociation is in psychiatric disorders and how that may be clinically relevant to consider. Earlier this month, an article called "What Does It Really Mean to Dissociate?" was published in the New York Times. In this article, the author explores dissociation and dissociative disorders, highlighting how frequently they are referenced on social media. TikTok, for instance, has over 1.7 billion views for the hashtag dissociative identity disorder. And it has another 790 million for dissociation. The New York Times article also highlighted a study presented as a poster at last year's American Psychiatric Association's annual meeting that looked at the quality of information shared in the top videos on TikTok and YouTube. While YouTube had a slight majority providing useful information, the rest of these videos were either not useful or misleading. On TikTok, only 5% of the videos were found to be useful, with majority being neither useful nor misleading. To me, it seemed apparent that dissociation and dissociative disorders are often discussed in social media platforms and elsewhere, but only rarely discussed in my psychiatric training. And I wonder, why is this? One reason may be around the controversy of the diagnosis of dissociative identity disorder, formerly known as multiple personality disorder, which began in the 1970s. I'm going to show a brief clip from a report called Semel, a Brilliant Hysteric. This report was based on a patient, Shirley Mason, also known as Sybil, who became a media sensation. The video starts out with the journalist, Debbie Nathans, discussing how the treating psychoanalyst made very specific suggestions to Sybil about these personalities. As a disclaimer, there is a mention of traumatic experiences in this clip that can be difficult to hear, and the video lasts for approximately 2 minutes if you would rather not listen.
Dr. Wilbur was looking for trauma. She had this idea that something terrible had made Shirley split. She didn't really know what it was, so Shirley would be questioned pretty ruthlessly about things that her mother might have done to her, with a lot of specific suggestions by Dr. Wilbur. And what she, quote, remembered, unquote, was her mother tying her up, sticking implements up her genitals, all kinds of really terrible things.
Rather than publishing her findings in a scientific journal, Dr. Wilbur approached a journalist friend, Flora Schreiber, about the possibility of writing a mass-market book. She agreed, but only if Mason's personalities had merged. 3 years later, Schreiber got a call from Shirley Mason.
Flora Schreiber came over to Shirley's apartment, and she'd had some sort of a fit. She fell down, writhing, and then jumped up and jumped all over the place. After that, she was integrated. That's the way it was described by Flora Schreiber. She was integrated.
Their book, Sybil, sold more than 6 million copies.
You call me sweetie?
And the TV movie that followed was a smash hit, turning the story into a sensation.
My next two guests have an amazing and frightening story. Will you welcome, please, Dr. Cornelia Wilbur and Professor Flora Schreiber. This is just one of the most fascinating cases, I guess, that's ever happened in psychiatric history. Do you have a feeling that there are a lot more of them that never come to light?
Yes, I do. Except the doctors don't recognize it.
Has anybody suggested this is a hoax? He needed some evidence.
Hoax has been breathed down our necks by various people at various stages of this project. Actually, it isn't a hoax. Tragically, it isn't a hoax. It would be much better for Sybil and possibly for all of us if it were, because this was dreadful to bear. This is true. It doesn't sound plausible. It doesn't sound possible, but true it is.
Before Sybil, multiple personality disorder was so rare that only 100 cases had ever been reported in the medical literature. Less than a decade later, in 1980, the American Psychiatric Association officially recognized the disorder, and the number of patients diagnosed rose into the thousands.
The discomfort we may feel around dissociation might be rooted in cases like Sybil's, where there was an idea that the psychoanalyst implanted a fantasized idea of multiple personalities, and that this diagnosis was iatrogenically created by mental health professionals. Another reason that dissociation may be disregarded is in the definition of dissociation, which is considered to be vague, confusing, and even controversial. In the DSM-5, dissociation is defined as a disruption in consciousness, memory, identity, emotion, perception, body representation, motor control, or behavior. How did we come to this definition? In early literature, dissociation was conceptualized at the level of the psyche, describing a particular psychological organization, and this division of consciousness resulted in the clinical phenomena of hysteria and ultimately linked to traumatic experiences. Much later, in 1980, the DSM-3 shifts to a phenomenological classification and groups dissociative experiences under the new heading, dissociative disorders. And dissociation comes to be seen as a very broad set of experiences and symptoms characterized by a breakdown in normal integration. Today, dissociation is a continuum ranging from normal to pathological. And we can see that using this broad definition gives us no clear definition. Based on this continuum, self-report questionnaires were developed. One of the most widely used scales in research is the Dissociative Experiences Scale. This was built on the assumption of a continuum, so includes normal to pathological dissociation, and produces a score based on percentage of a time an individual experiences each dissociative symptom. Use of this scale is also relevant because observable dissociative behaviors have not been reliably assessed by raters, and so dissociation is viewed essentially as a subjective phenomenon. So when do we see pathological dissociation? Of course, we see dissociation in the dissociative disorders. However, I want to focus on where we see pathological dissociation beyond the dissociative disorders. Within the DSM, there are a number of other disorders referencing dissociation in the criteria. These include post-traumatic stress disorder and acute stress disorder, which can include a number of dissociative experiences, including alterations in memory and post-traumatic flashbacks. Post-traumatic stress disorder has a new specifier in the DSM-5 for a dissociative subtype of post-traumatic stress disorder if depersonalization or derealization is experienced. Conversion disorder symptoms are also including dissociation, and in the ICD, conversion disorder is considered a part of the dissociative spectrum. And finally, borderline personality disorder can include severe dissociative symptoms. But dissociation is not limited to just these diagnoses. In a meta-analysis from 2018, looking at over 200 studies using dissociative experiences scales, they found dissociative experiences were present in a wide range of psychiatric disorders. The largest dissociation scales were found in dissociative disorders, post-traumatic stress disorder, borderline personality disorder, and conversion disorder. Dissociation was also seen in eating disorders, anxiety disorders, OCD, schizophrenia, substance-related and addictive disorders, and mood disorders. This suggests evaluation of dissociative symptoms may be relevant not only for dissociative or trauma-related disorders. Within the dissociative disorders, we see 5 core phenomena of dissociative psychopathology. These include dissociative amnesia, derealization, depersonalization, identity alteration, and identity confusion. But what about dissociative phenomena outside of the dissociative disorders? Using our current focus on phenomenological description, assessment for dissociation beyond the dissociative disorders focuses on the subjective symptoms of pathological dissociation. Paul Dell, a clinical psychologist, categorizes these into 6 symptoms that are consciously experienced as intrusions into executive functioning and sense of self, and they may be seen in both dissociative and non-dissociative diagnoses. Why might these be important? A number of studies have suggested that dissociation is associated with increased illness severity, treatment resistance, impaired performance on attention, executive function, memory, social cognition, self-harm, and suicidal behaviors. A full discussion of treatment for dissociation is beyond the scope of this talk, but briefly, treatment is based on the primary diagnosis. For dissociative disorders or other disorders where individuals are experiencing extreme dissociation, treatment involves a phasic, multimodal, trauma-focused psychotherapy. The first phase involves establishing safety, stabilization, and symptom reduction. Phase 2 focuses on confronting, working through, and integrating traumatic memories, and Phase 3 involves integration and rehabilitation. Medication is not the primary treatment, but it can be used to help with symptom stabilization and to treat comorbidities. Although the current literature has many limitations and the concept of dissociation is further limited by its broad definition, dissociation remains a popular topic in the news and in social media. Beyond this, I have directly experienced how common dissociation is among my patients. However, I have had little time and space to explore and think about the relevance of these symptoms for my patients. Even in deciding on this topic for my head talk, I felt a sense of discomfort, a sense of, should I even be talking about this? And I chose to lean into that discomfort as I hope to better hear and support my patients who share with me their dissociative experiences. As Dr. Richard Lowenstein states in this paper on dissociation debates, there is a fantasy that the patient who experiences dissociation does not exist and that they have been iatrogenically created by the mental health professional. However, by not assessing and treating dissociation, we harm our patients in society, and that is the real iatrogenesis. Thank you all for your time, and I specifically also want to thank Dr. Howell for giving me the space to think about dissociation and for assisting me in preparing for this talk. Thank you.
Thank you, Hilary. And just wanted to say thank you to all of our speakers for today. Taylor, Jinit, Hilary, just all really incredible talks, gave me a lot to think about, and I'm sure gave our audience a lot to think about as well. So thank you for the time that you put into preparing for this. All right, so yeah, go ahead and submit any questions that you have in the Q&A. It looks like we have some rolling in already. It looks like our first question is for Dr. Smyth, asking, can you share your thoughts on the balance between personalizing treatment versus setting standards for good practice, and how you try to achieve that particular balance?
Yeah, absolutely. I mean, for me, I think one of the biggest advantages of an approach that involves relational pharmacotherapy is that it actually provides this kind of containing and conservative effect that might actually help clinicians to hew closer to the existing evidence base. There's a great paper written in 1957 by Thomas Main, which was really kind of one of the first descriptions of borderline personality disorder in the literature. And in the paper, he talks about reactions among the staff on a unit that is really composed of these patients. And he describes this phenomenon of the clinician's refusal to accept kind of therapeutic defeat, which can lead to therapeutic mania and desperate treatments, polypharmacy being one of them. And so I think that this approach can help us to actually adhere to evidence-based guidelines for the individual by helping us to manage feelings of helplessness and inadequacy that might arise in the treatment of these patients sometimes.
Yeah, thank you. We have a question that came in for Dr. Wright. Would you consider the extreme focus in a riveting movie as a form of normative dissociation?
Thank you for that question. I think that in the movie, which I haven't seen Sybil the movie, but in social media and in the media, I think that there is possibly a part that's normalizing dissociation, and I think that that can be good because dissociation can be a normal phenomenon. But I think it's also important to consider the influence of the movie, and especially currently in social media. I'm not on TikTok, but I'm sure a lot of my patients are, and they're being exposed to a lot of videos about dissociation and dissociative identity disorder, and many of those might be misleading. And so I think it is important for us to normalize dissociation when that's appropriate, and then also to consider when it's pathological and really interfering with our patients and considering it on that end as well.
Yeah, and as a follow-up question to that, something that crossed my mind as you were giving the talk, you mentioned just how prevalent dissociation is as a topic on social media. And I'm curious, do you feel like that's simply due to the widespread availability of social media, or do you feel like there's something about the current time that's making it a very salient topic? Any thoughts on like what might be contributing to that rise that we're seeing on social media?
No, I think one of the leaders in dissociation kind of commented on that, and the idea that we would hope that the internet would sort of bring us all together and make us feel all more connected. But actually, I think a lot of us feel more fragmented, more socially isolated, more apart. And so I wonder if it comes from that. And I think in people who are expressing concerns about dissociative identity disorder or dissociation, like talking to them about those concerns and like what they've seen in the media or where it's coming from for them internally and why they're thinking that and experiencing that. And this idea of maybe we're all very disconnected because of social media as opposed to more connected.
Fascinating. Got a question come in for Dr. Desai. Is there an example of a patient that you've seen for whom the concept of enactment may have redirected how you treated them, perhaps towards a more humanistic approach?
Thanks, Dr. Tu, for that question. Yeah, what comes to mind is psychosis clinic, and when the reality that the patient inhabits doesn't totally overlap with that of others, and when someone comes in with conviction that we don't share, there's always the question of how do you go about it? Do you challenge it or not? When do you challenge it? And is it relevant to the outcome if it's been a long-standing one, if they're doing okay otherwise? I think that enactment could help us understand why certain delusions arise and why they're so tightly held. If someone has lost all meaningful relationships, is no longer able to work, and is struggling to make meaning of their experience, that other people can also attest to. The delusion might provide some of that existential relief that most of their life otherwise doesn't provide. That's not to admit prematurely to therapeutic defeat if the delusions are endangering them or their family, but that we don't see things the way they do. I find that I don't always push to eradicate it right away. I try to understand what purpose it serves them before trying to treat it, so to speak.
And as a follow-up question, something related to that I wondered about during your talk, you mentioned specifically in psychosis clinic how this is something that you've seen be relevant. Are there specific disorders or categories that you feel like an enactive approach is better or others that you feel like it's not as well suited, or is it something that can be applied pretty generally across the board?
Thinking about Dr. Smyth's talk on treatment resistance, I I wonder if there's a role to play there too. It made me his talk made me think about a patient of mine who he's failed a number of antidepressant trials, and there's a part of him who longs to be somewhere else. And at some point, after a number of treatments have failed, one has to wonder if the treatment target is the right target, and or if there's something that we're not bringing. And in a medication management treatment clinic, we're probably not bringing the meaning making and the alliance in the same way that we could in another setting. Treatment resistance, and in particular mood, where someone's cognition is usually a little bit more intact than in severe psychosis. That dialogical sense making and relationship building might help serve the patient.
Thank you. Dr. Smyth, I think this question is for you. It came up as you were giving your answer earlier. Given the placebo effect, which we've known about for centuries, why is the medical field so reluctant to use that in clinical practice?
I think that's a really interesting and complicated question. There's a lot of different answers. I would say, I think one finding that was interesting in a study that was published back in 2016 is that there does seem to be kind of a discrepancy between empirical evidence on the role of nonspecific effects in pharmacological treatment outcomes and clinicians' beliefs about what is really contributing to treatment outcomes, whether it's nonspecific effects or specific biological effects of the medication. And I think that part of that does come out of our training as doctors. I think a lot of us go into this field because we want to help people, and we want to help people by doing something. And prescribing a medication, I think, feels like we are able to use our skill set and our knowledge base that we've developed to do something to potentially help someone. And it might feel like defeat to recognize the limitations maybe of the medications that we have. I think it also might serve to kind of resolve some of the discomfort with the complexity and the ambiguity of treating patients who are coming in with very kind of individualized manifestations of psychic distress. So for all of these reasons, in addition to just kind of the financial reasons, right, why drug companies would never finance a study on an open label placebo trial, which I know that Ted Kapchuk and his team up at Harvard have actually kind of floated to the FDA, given some of their studies that they've done on other open label placebo trials, which are really fascinating. So maybe something that might change going forward, but I think it's a very kind of multifaceted phenomenon that we see.
Yeah, that makes sense. Thank you. This question is for Dr. Wright. Do you have any advice about how to distinguish between or conceptualize delusions about having multiple personalities, as in someone with a schizophrenia diagnosis, versus a dissociative disorder?
That's a really great question, and I think a really interesting one, even in the literature, more recent literature. I think, as a basic idea, we think of dissociation as a feeling of not being able to feel connected to reality, a feeling of disconnection or not feeling integrated. While in psychosis, we think of that as an inability to really distinguish what's real and what's not real. So that might be a good starting point. But in more recent literature, there's some interesting discussion around the idea of how dissociative phenomena are related to psychotic phenomena, and if at times psychotic phenomena for certain individuals, especially ones who may be treatment resistant, might have sort of a dissociative component to their auditory hallucinations or visual hallucinations. And so some recent meta-analysis has shown that there is an association between positive symptoms in psychosis and dissociation. And that could be really relevant because that could be a really strong place for intervention. And so there was a recent pilot study looking at an intervention called Talking with Voices and using a sort of dialogue intervention to see if that could be helpful for that type of phenomena. And so I think there's a lot of interesting research still to be done on that topic.
A few quick questions that came in about dissociation as well. How would you view amnesia during extreme anger? I guess, would you view that as kind of a dissociative symptom or not?
I guess it would depend on how it's presenting clinically. If the person was coming to you and expressing an inability to remember something that happened when they felt really angry, I would just kind of be very explorative with that with them and asking about that experience, how it's impacting them, and really just kind of trying to understand better their experience and also why this experience is significant to them and why they're sort of bringing it to you and how you can kind of support them in that. Within dissociative amnesia, we think of that as amnesia that's referring to not being able to recall important personal information that is way more extensive than ordinary forgetfulness, or the idea that really significant or important events are forgotten, such as abuse or something really troubling. And so, it could be thought of dissociative amnesia if there's some component there of that. And then more generally, as a dissociation, we can also see just general memory problems. And those might be just non-specific difficulties in memory collection, poor day-to-day memory, ongoing forgetfulness, that are distinct from frank episodes of amnesia. So I think just starting with further exploration would be a good place.
Yeah. And then the follow-up question that we got, any link between religious beliefs and the ability to combat dissociation? Like, do people with strong religious beliefs have higher or worse or higher or lower rates of dissociative experiences?
I actually haven't looked into that in the literature, but that seems like a really interesting idea and something that I would be curious to read more about.
And a question that came in for Dr. Smith, how much of our prescribing might stem from the psychiatrist's need for relevance in an environment where we've been essentially cut off from being more effective psychotherapists, kind of looking at like the environment, the current practice environment that psychiatrists find themselves in?
Yeah, I mean, I would have difficulty quantifying it, but I certainly think that that's probably contributing to the trends that we've seen. I think the identity of a psychiatrist has hewed more and more over the years towards being a psychopharmacologist. And part of that is reflected in the training that we get as well, where, we start on the inpatient units. There is immediately kind of a big emphasis, and kind of rightly so, on learning how to use these medications, and maybe some of the psychosocial interventions that we have available to us to really operate at the top of our license aren't kind of brought out into the mainstream of our education and training until a little bit later on. And by that point, we might have already internalized kind of that role as psychopharmacologist, which may make it harder then to really kind of use those other kind of non-drug skills on an even plane, I think. So part of it is just kind of the confidence and the feelings of competence that psychiatrists might have going out doing the work that they can. But I think this issue of operating at the top of your license is interesting, because I know some jobs will say, we expect you to operate at the top of your license, which means prescribing medications and being a psychopharmacologist. And really, I think that this is kind of our niche in the market, which is really having the two perspectives and being able to implement a pluralistic approach to treating individual patients that incorporates skills from both psychotherapy and psychopharmacology.
Yeah, thank you. So I know with kind of a short format, there's often this question of like, what do I take from this? Where do I go if I want to learn more? So maybe I'll ask each of you that question just to kind of end our Q&A. For somebody who's interested in learning more about the ideas, the topic that you brought up, what would you suggest as a next step for them? Maybe we can start with you, Dr. Desai.
Yeah, thanks again for the platform, Dr. Hull, and the encouragement. Yeah, I think, a paper that I recommend is Gomez, Carrillo's, and Kiermaier's 2023 paper, Frontiers in Psychiatry, on the cultural eco-social systems view of psychiatry. It brings together an activism, but also helps to put forth a notion of dynamical causality that might lend itself to intervention and prevention efforts in the future.
Dr. Wright, any thoughts on your end?
Sure. The International Society for the Study of Trauma and Dissociation, kind of a mouthful, but they provide a lot of really great information for prescribers, for non-prescribers, for patients. They have guidelines based on what type of evidence we do have, and that's a really good resource to start with.
And Dr. Smith?
Yeah, I mean, I would wholeheartedly recommend David Mintz's book that was published back in 2022 that's called Psychodynamic, Psychopharmacology, I think it's Caring for the Treatment-Resistant Patient. If you want something a little bit shorter that has a lot of the core ideas in there, there's a wonderful article that he wrote with David Flynn back in 2012 that's called How Not Want to Prescribe Non-Pharmacologic Aspects of Psychopharmacology, and both of those would be good places to start.
Thank you again to the three of you for just really fantastic talks and for this really enriching Q&A. We'll go ahead and break for today. And just wanted to say thank you to all of you for joining. And yeah, this will be our last grand rounds for 2023, but we'll be back January 2024. All right. Thank you, everybody.